Hello and welcome to The Rest is Plastics, the podcast from the Journal of Plastic, Reconstructive and Aesthetic Surgery with me, your host, Anton Fries.
And me, James Chen.
This is a great episode. Today we're talking about a really fascinating paper in the journal. This is the 2024 EURAPS Expert Consensus on breast implant-associated anaplastic large cell lymphoma.
Professor Fabio Santanelli, the Pompeo, is the senior author on this paper. He's chair of plastic surgery at Sapienza, University of Rome, and head of the plastic surgery unit at Sant'Andrea Hospital, and a former president of EURAPS. He's been a leading European voice in breast reconstruction and in the international response to BIA ALCL.
He's even most recently been appointed to the Ministry of Health in the Italian government. And we spoke a little bit about that as well as the paper itself. It's a fascinating episode and I really hope you enjoy it. We're very excited to discuss your paper. You're the senior author and also, I guess, convening expert on this consensus on breast implant-associated anaplastic large cell lymphoma. Obviously, this is a really hot topic at the moment, but perhaps you can tell us and the listeners why you chose to discuss this topic.
Thank you very much for the invitation, of course, for the podcast. I'm very honored. The reason why I decided to discuss about this topic is because it's my last prevalent interest since 15 years, probably. I've been publishing more than 27 original papers on the topic. So because of those papers, I am the most expert on literature about the topic. I find very interesting to try to put effort in solving a problem that we created ourselves to the patients, which is definitely unfair. So it's our duty to put any effort in it.
Please, can you describe the methodology of this expert consensus?
Yeah, I had the idea to set up a study following a structured Delphi consensus process to develop an expert statement on BLCL. So we started on October 2022, and EURAPS national delegate, because EURAPS has several different national delegates for each nation that belongs to EURAPS, and where there are no delegates, we contacted the society, national society of the countries, and we asked the leader of the societies to appoint a plastic surgeon or an expert. So altogether, we appointed 24 international recognized experts, including specialists in basic science, biostatistics, in immunology, in oncohematology, pathology, and 19 plastic surgeon experts on devices, implant, and BLCL. All the conflict of interest of these participants, of this member, were publicly disclosed on the EURAPS website and by all of the participants, and none of them led to an exclusion of the panelists. Then the panel was divided into three chapters. The first one was based on the epidemiology and causality. The second chapter was on etiopathogenesis and diagnosis, and the third one was on treatment. And each of these chapters was overseen by a dedicated chairman. So between October 2022 and November 2023, so 13 months, we did a systematic literature review, and it was performed according with PRISMA guide. So we investigated multiple databases like PubMed, Scopus, and more. And we searched for specific target terms related to breast implant and to lymphoma. We included only English language human-focused studies that were addressing BALCL. It were not included non-English works, and of course were excluded duplicates and studies not related to this pathology or other implant-associated pathologies, and non-human research, only on human were included. Then two independent reviewers screened all of these studies with dispute resolved by a steering committee chair. The findings from all of these studies form a draft consensus statement prepared by each chapter chair. Beginning from February 2023 to February 2024, so it took us almost 2 years, to run this consensus, 4 online Delphi meetings were held. Absent member that could not join the meeting, anyhow, they received a recording of the meeting and could provide inputs by email. At each stage, statements were rated on a 5-point Likert scale to measure agreement. Of course, with a lower quartile score, higher or equal to 4, means acceptance of the statement. Lower upper quartile than lower than 3 led to rejection. Interquartile, of course, including 3, was not sufficient. And then we had to do another round of consensus. So additional qualitative feedback helped to refine the statement for the final consensus document. That was our methodology that we adopted.
Fantastic. So obviously, not only plastic surgeons but in this group, but also other experts as well. So that's, as you mentioned conflict.
Definitely.
You mentioned conflict of interest in your sort of opening remarks, and I guess that's the first thing people will see when there's a paper in a plastic surgery journal written by plastic surgeons about breast implants. That's something people will want to understand. So that's great that you had that process and that breadth. You talked about the consensus and the scoring. So obviously there's a methodology to the scoring, but in lay terms, what were the challenges to achieve that consensus? Particularly when this is a rare condition, but also serious, but also with a lot of media interest.
Yeah, of course. It was a very challenging program, and the chance were low to achieve consensus. But I must say that we were very lucky. We achieved most of the consensus, or we achieved consensus on most of the statement at the first round. We only had to go back for a couple of statements the second time. But I think that the secret of the success was that we had the opportunity to select highly talented experts and scientists on the field. And when you recruit honest scientists, then it's possible to find and achieve a consensus on the topics, because all of them were reading the literature, studying, and so there was no discussion about opinion. It was just interpretation of the existing literature.
You talked about how you broke this down into the 3 chapters. Chapter A, epidemiological and causal aspects, and then chapter B, pathogenesis and etiology, and then chapter C, which was diagnosis and treatment, and each of these had their own research questions. I wondered whether you could kind of summarize the main points you would like to emphasize. So there's a lot there.
Yeah. I think that the main point that I like to emphasize is that about this study is, on one hand, we are aware that we cannot generally explant all patients with texture implant, as well as not all patients would like to have it explanted. But on the other hand, we cannot neglect the part of this patient that would like to have it done, because there are some patients that would like to remove those texture implants. So we have to consider all the possibility and all the patient expectation. So, of course, it is already possible to explant under the indication of cancerophobia, but there are still a lot of financial speculation on that issue, and especially on explantation, because it's not easily done by the national healthcare system. So, unfortunately, those patients should go privately. We should give a chance, I think, by this statement, we should give a chance to women to find easy opportunity to explant without financial distress, as well as we have to give a chance to surgeons who do it, to do it without being out of guidelines, because at the moment, most of the guidelines blow in the direction of not indicated the explantation. So I think that the decision should rely in the hand of the surgeon and the patient. I mean, is the patient right to get explanted a device that is potentially dangerous? Doesn't matter how high or low is the risk. There is a risk, as been stated, and I have to feel confident that I can go to the healthcare system and ask for it. I'm sure it was done in the States, the test, and not all of them goes for explantation. Only very few goes for explantation. But nevertheless, if a surgeon decides to explant a non-symptomatic patient with texture implant, it should not be considered a criminal. It should be considered just an activity that is within guideline to accomplish patient desire. So I think these are the main points that I like to stress. I mean, nobody wants to run for general explantation of texture device. We just want to go for stratification of the risk and listen to the patient. If they are willing to do it, then we can, the doctor should discuss with the patient about the benefits, about risk of both keeping the implant or running the procedure of explantation, because of course, it's not free of risk, the explantation. The main risk about explantation is usually bleeding after surgery. So you have to go to a revision, more than one surgery, and of course, that's not fair.
You mentioned people having guidelines to support our practice, and that's obviously one of the great benefits of this work that you've done. Are there other international guidelines regarding treating the BILCL, and how do those recommendations compare to the EURAPS ones?
Yeah, there are other guidelines which are very well reputed, like the guidelines from the American Association of Plastic Surgery, and as well from the National Comprehensive NCCN guidelines, the organization. And it is a non-profit organization run by, don't remember exactly how many, 18, 19 something of major oncologic hospital in the United States. So it's the very high reputation. I think one of the most important recommendations is still about the key point is the prophylactic explantation of those implants, because that's the stone of disagreement. And the American Society recommendation, as well as the NCCN guideline, they do recommend prophylactic explantation of microtexture surface implant can be deemed reasonable. So it's not a mandatory recommendation that you have to do in all of the patients that step into your office, but is deemed reasonable. It's reasonable to it's reasonable to explant a patient which is not symptomatic. So this is quite important. These are recent guidelines, as well as like the EURAPS guideline. The most important, as I said before, is the stratification and having a surveillance plan. So we have to go for wide, broad, and well-structured informed consent with the patient, so that the patient can decide once is totally informed about risk and benefits. The other important, I think, consensus guideline agreement between more than an association is about the evidence of the ethiopathology. So it's definitely well established that the pathway involves chronic inflammation and then the acquisition of a driving oncogenic events that may be considered as an increase in the risk of developing BLCL only in patients that have been exposed to textured breast implant. This is quite important to talk about exposition, because you might have nowadays a smooth implant, but if you got a textured implant before, you still can be considered a patient at risk. There is not a single case around the world where a patient has been exposed only to smooth implant and then they got BALCL. the case that was discussed and reported in FDA, when we invited at our Work Consensus Conference in Italy, Benita Ashar, which is the director of the FDA, she confirmed that they cannot confirm the history of this case because it was not complete. So far, we have to consider that any patient exposed only to smooth implant is totally safe from this disease.
Yeah, it's fascinating, isn't it? And particularly that piece about the patients who'd had previous exposure, which of course ties in with the non-symptomatic explantations. Is it known what rate or how common or are there differences in different countries of patients coming forward looking for asymptomatic explantation of textured implants? Is that a very common thing or less so?
No, it's not that. Definitely not so common. Probably it's surprising. It's very interesting because the country that raised more interest on BSL is United States. Actually, the problem in the States is very limited because they had only something like 5% of the market. It's texture, 95 is smooth. So it's a very limited problem. While in Europe is the other way around. We had something like 95% texture. Now it's decreasing a lot, the texture. Most of the market is shifting from macro texture to micro texture and to smooth. So the smooth percentage is raising a lot in Europe and in States too. I mean, in States probably it went from 93 to 97 smooth implants. So it's very limited, the use. Nevertheless, I mean, most of the patients that claim about explantation, it's more a phenomenon in the States than in Europe, but it's also in Europe considered. It's a problem of awareness. Not all the patient knows about BSL. In the States, probably media and some special cases raise the attention of the patient a lot. In Europe, less probably, so not all the patients are aware. But slowly, I mean, with the education and with the awareness, the patients are coming. But there is a problem. When you wear a texture implant, is not forever. So by several reasons, you may end up in replacing the implant because of rupture, because of malpositioning, because of capsular contraction. So those patients go for a revision and then move from texture to smooth by themselves. So it's just, a smooth process for changing.
The main thing I'm getting from this conversation is it's very nuanced. It's a shared decision-making process between the surgeon and the patient. But are there other ways in which your findings should inform us as plastic surgeons more widely?
Yeah, I think that we are close to publish another paper, which is under review now in PRS. And we focus and we did a study on the device itself and the surface. So we find out that the most reason why we end up with this problem is most probably a problem of friction. There is a continuous inflammation. What we believe that is stable is not moving, the texture implant. Actually, it undergo two micro movements. Those micro movements create continuous apoptosis, inflammation, and recruitment of cytokines for inflammation. These lead to oncogenesis and transformation of the T cells. What we should know as a plastic surgeon, probably the most important is that some patients, especially those with BRCA1, BRCA2 mutation, germline mutation, or patient with the TP53 gene mutation, those patients has been demonstrated to have higher possibility of having BSL, as well as they go into BSL much earlier than patients not having those mutations. So there are germline mutations, not specific of BSL, that can promote the onset of the disease. So I think this is the most important. If we have a patient like BRCA or like TP53, let's say post-oncology patient most often, probably we should take the decision to go for a small implant more than continue using the texture implant. I think this is quite important. And, probably even if we have to take the responsibility of operating a young woman, when a woman starts with a breast implant, probably from 18 years old, she might go on for 40, 50 years with this implant. So we have to probably take the wisest decision to give her the chance of having a device that is less creating problem. She doesn't need to replace too often, and definitely not running into BLCL. So that's what I think that we have to consider. Of course, most of those consideration and statements are published under my name on main review and main journal like PRS or Aesthetic Plastic Surgery, and our forthcoming papers.
Fantastic. So, I mean, this next question really leads on from the comments you just made about, this concept of friction and chronic inflammation. We talked, and you gave us some advice about practically looking after the patients. From a scientific perspective, the knowledge gaps that you've identified in your consensus, you make some comments that, it won't be possible to do randomized controlled trials. And I'm really excited to read your paper, in the next paper coming out. Where should we direct our efforts scientifically? Is it the friction or the inflammation, or I guess both? But how should we target our scientific understanding of the pathogenesis of this problem?
Yeah. So let's consider that this disease, of course, is quite rare, and probably if it's difficult to solve the problem of treating a cancer, it's probably even more difficult to create a cancer. And that's, of course, the impact with the research study. So it would take, in human, 10 years probably on average to create a BLCL. It's impossible to do it in the experimental conditions. That tell us how difficult it can be to find solution. Nevertheless, we are forced to find as more information as possible. Just like cancer in tabagism, we have a moderate level of evidence for BLCL, like the lung cancer for smoking user. And this, of course, it's a level of evidence which is moderate because we cannot replicate the BLCL and we cannot study to that level. The only possibility we have and is left is to do case match studies, because we cannot do randomized control studies. It would be not ethical to implant a device which is potentially dangerous in a patient and waiting for a cancer. So as like for smoking, we can go with the case match studies. That's what we have done. And I told you before, we've done a case match study with 1,000 of patients in 3 different countries. It will come soon, hopefully, on TRS. And we focus on the device itself. So we have to go to collect those studies. And what we could find out, which is also very important and interesting, in the common narrative, we know that this BLCL is combined with Allergan brand. Well, from our study, from our case match study, which is the level 2 of evidence, is the highest possible that you can have in this field of research, this is not true. It's not a problem of Allergan, but it's a problem of any texture implant, with no difference between the level of roughness. So even micro texture implants have the same level of risk, possibly higher, but not statistically higher. So they are all in the same basket, the texture implant.
It's a wonderful summary of a great paper, and that was fantastic.
It's I would recommend everybody to really dive into this paper. It's a fantastic review, very, very clearly spelled out into very digestible sections. So thank you, but it's nothing better than hearing it from the horse's mouth, so to speak. Let's pivot to something a bit different, because you are in a governmental role now. So can you tell us more about this role in the Italian government? Because it's so exciting to have a plastic surgeon holding such a position.
Yes, thank you very much. I have to say that I'm very honored that the Ministry of Health choose me for that responsible work. I still wonder why, but probably because, I don't know, level of science for sure, because they've been investigating my curriculum, but probably also for, how to say, transparency and honesty in dealing my job. I should say that this is a very, very well-respected position, and it's very important, with no, only, how to say, I'm paid back for the cost. So it's not a position that I gain money with the government. But on the other side, I wake up after this position, employment, I wake up 5 o'clock every morning, and I work for the government from 5 o'clock to 8 o'clock, 3 hours every morning. And then I start to my routine job. The point is that those first 3 hours of the day, I have to dedicate it to things that I was not aware of until a month ago. So it's a new life, a new job. At the moment, I have to take care of the ethical committee, national ethical committee. It means that I review all the European research projects, not only on plastic surgery. Mainly, there are devices involved, but anything, for orthopedics, neurosurgery, everything. And I have to look into those projects, find bugs, and highlight the bugs and discuss within the committee. And it's very exciting because on one side, I expand my knowledge, which I was getting narrow, concentrated on plastic surgery only. Now I can speak about many things. And of course, it's on advanced therapy. Of course, this is one part of my job. The second part of my job, which is a counselor of the Ministry of Health, any problem is raised in the country. Like, I can give you an example, the teaser to be used for policemen. So the Ministry of Health want to have the opinion about using or not. Then we have to go into the device, risk, pro, cons, and there are several committees that they have to analyze this problem by different aspects. We took care, I personally work in the commission number 5, which give the opinion among the device itself, if the device is safe or not. But there are, of course, other ethical commission, other human commission, and any kind of commission in order to finalize the decision. Okay, it's wise to use the teaser or not. That's it. What I do almost every morning, and we meet every second week with one committee, and every second week with the other one. It means that every week I have a commission to attend.
Wow, that sounds exciting, but very tiring and daunting. But congratulations. I mean, I can hear the passion in your voice when you're talking about this. It's fantastic. And I guess we as plastic surgeons are well suited for something like this, actually, because by nature we work with different specialties, don't we? And we are very collaborative. And so you're in a perfect position to talk to all these different specialists.
Yeah, you're right.
Perfect. Well, Professor, we're very grateful for your time, very valuable time, and it's great to speak with a leader who's transcended our specialty as well. So, thank you so much for coming to join us on the podcast.
Thank you, Anton and Jens, for the invitation. I was honored, and I enjoyed very much to discuss with you about this paper.
Well, that was a fascinating discussion, very broad-ranging. It's great that, this is obviously very of the now, and it's great that this evidence is being accumulated and this sort of evidence-based advice is being disseminated, I guess, so we as surgeons in Europe and across the world, can act in the best interests of our patients.
Yeah, I mean, there's so many points we talked about, but I think one of the things that really got me was when he said that he felt it was our duty as plastic surgeons to really lead on this problem, because it's almost an entirely iatrogenic problem that we've caused actually. And that really hit home to me. And so this is an absolute must read for breast reconstructors, but also all the trainees coming up to their exams.
Yeah, absolutely. And I thought he made that point quite strongly. And it was interesting as well, wasn't it, his pivot into a plastic surgeon now working in the sort of higher levels of the Italian government, which was quite fascinating.
Yeah, so portfolio careers.
Absolutely. And I guess finally, I mean, the other thing I really took away was, the shared decision-making aspects and, particularly perhaps from some of the asymptomatic cases and, patients with textured implants and requesting explantation, and that should be supported.
Yeah, and I think it's really good actually to have some guidance on this, because he was saying that you can almost feel guilty as a surgeon doing explantation, like you've done something wrong, but actually it's for prophylaxis and is to reduce the risks of ALCL, however small they may be, particularly in young patients who have many more years to live.
Great. Well, I hope you enjoyed that discussion. Please leave us a review, like, subscribe, and consider submitting your research to the Journal of Plastic, Reconstructive and Aesthetic Surgery.
Until next time, the rest is plastics.